I'm really delighted to be here. And thank you for to the planning committee for inviting me here. I, first of all, really want to ask for some grace in terms of the time. I think this is a really, really important topic. And so when I was asked to present for 30 minutes with community members and a diverse group, I said, I need to figure out a way to really talk slowly and make sure everyone understands. And so I'm asking for grace if this presentation goes a little bit beyond that because we really need time to delve into this. It's very important. It's a topic that I'm really passionate about because I want to make sure we're doing the right thing. And I want your bioethics forum and your consortium to be one of the leaders that are doing the right thing. So the focus of my talk is going to be how we can help advance health equity, especially in this era. And I'll really focus on ethics, right? I talk about ethical AI. I know this is bioethics, but and I looked at bioethics, and bioethics is more biology and biological systems, but I think you're really doing all of ethics as well, especially when it comes to AI. Most of my work has focused on in the AI space, how we can really leverage these technologies to advance health equity. And I'm coming from the perspective as a physician, as a public health professional, and my concern about how it's going to be used to make decisions for patients, for communities, and for families. And so I'm going to really focus on that aspect and how we can all identify how biases in the data can creep into AI and how we can help lead the way, because we cannot wait for AI developers and we cannot rely on them to do it. I think it's all of us that needs to be part of this network. So I'm going to basically start with the two key messages that I want us to take home with, which is that all of us should be in this together, right? We as health professionals, health researchers, bioethics ethicists need to play a critical role in this effort because we're part of ensuring that optimal health for everyone. It's not just the artificial intelligence developers. It's not just physicians and nurses. It's researchers as well. We all need a critical part of it, and this is because the research data and the research evidence that you all generate, that is the foundation for what's being used in AI. And so we need to think about that, and we need to think about how these data can be integrated into the technologies for the benefit of everyone. And then the second part of it is there's not a lot of investment right now, in my opinion, in addressing the bias or the ethics of AI. There's been consortiums, there are coalitions talking about it, but we need to invest more effort into that, right? We need to not just talk, but we need to really put money into it. And I'm going to present sort of a lot of information about how we can do this together and address especially the biases that we all fear in this sector. So I told you my perspective is mostly from medicine and from public health, right? There's been a lot of transitions that require us to use data, a lot of data and a lot of technologies. And that's why some of us are optimistic about these AI machine learning technologies, because what we're doing right now is harming. I mean, that's where we have disparities. We are moving from the one size fits all medicine to precision medicine, right? Right now, we're currently practicing medicine with clinical trials that have been conducted in homogeneous populations. And so if we have to move to precision medicine, where we are focusing on care that is basically specific to patients groups that are similar, we can no longer be practicing with the research and the data types that we have been practicing on for so long, on making decisions on. So that's one. we're transitioning from one size to precision medicine. The second is right now we are working in multidisciplinary teams within our hospitals and healthcare systems. Right? It used to be just you go to your physician, they prescribe and what they want, and then you go out and you take it and hope that it improves your health. These days, a lot of hospitals and health systems have set up multidisciplinary teams. And so the focus is now on patient-centered approach. The patient is the center of healthcare or medicine, or should be. And so a lot of hospitals now have multidisciplinary teams, not just the physician, the nurse, we have nutritionist, physical therapist, whatever is needed to ensure that this patient has the optimal health or improves in terms of outcomes. And so to have patient-centered approaches with a multidisciplinary team, you need different sorts of data, social data, behavioral data, environmental data to make sure that we have optimal health for the patient. So that's second. The third part is we're also transitioning from when monitoring data just during a physician encounter, a hospital encounter, to monitoring data on a continuous basis, because health is also outside of the healthcare system. So there are now Fitbits, there are wearables, people at home can track their blood pressure or glucose, and we need to capture all of this because we cannot rely on data that is just within the healthcare system. And so transitioning to a continuous monitoring of patient data and coordination relies on advanced technologies or how to really analyze the massive amounts of data. The fourth is that we are now we're prioritizing value and quality of care, right? CMS and health plans that write the checks for our health is now moving away from volume, right, to value to improve the quality of our care, right? And when we talk about quality, we're talking about safety, we're talking about timeliness of the care, we're talking about how effective it is, how efficient, most important, how equitable it is, and patient-centered. And the last point of this transition is that we don't have a lot of resources in healthcare, right? And so we saw that during COVID, where we need to now optimize efficiency in our healthcare resource allocation. And to do that, sometimes we need to figure out how we can not waste resources, right? But make sure you're directing it to the people that need it most. And it may be in our communities, it may be, in social services, but we need that data to tell us that these are the most beneficial approaches to maximizing healthcare resources that are limited because we don't have infinite resources. So I tell you, that's why give me grace, because we need to go through this in a way that everyone will understand why we need to leverage and the best way to do this. I know that I have picked one up that there's been some definitions, and that's great. So I'm not going to go into detail on this, but I need to just put it up because I wanted to just touch on the surface, because it's good to hear it several times in different ways. I hear sometimes to understand something, you have to say it 7 times, 7 different ways. So let me go into a little bit more depth, or say it differently, about artificial intelligence. And I think it's written really well on this keyword concept paper. And so it's really a system that can make predictions, that can make recommendations. And it's typically done with large amounts of data and complex, especially to address complex issues. That is artificial intelligence. And I'm also speaking just in the healthcare space, right? Because there's a lot of different types of artificial intelligence uses. Now, machine learning and natural language processing are both parts of a component of artificial intelligence. And so AI in the healthcare space is like a smart machine that can help health professionals, doctors, nurses, social workers, to make better decisions and to provide improved patient care. And so these AI tools can analyze a lot of data like images and identify patterns. It's being used, very well in radiology or imaging, where the AI can detect changes in those pixels, where sometimes radiologists mean that, you have to have 100, what's it called, 20/20 vision, right? And so it's really helped in radiology to say, there's a change in this pixel pattern and you need to own your eyes on them and identify if it's a lesion. Machine learning, I said, it's a subdomain of artificial intelligence, and it refers to a family of algorithms that can look at patterns in health data, and it makes predictions based on these patterns in health data. And then deep learning is a component of machine learning. And I know that the panel will talk about that. And so I wanted to also include natural language processing, which I did not find on here. And that's another system of algorithms or programs that can understand language, written language. It can interpret written language. It's like giving computers the ability to understand and interact with human language. And so sometimes it's being used to read electronic medical records. Right? And then natural language understanding is that subset. So it deals with machine comprehension. And it's defined how machines can understand human language and behavior. And so that's okay. And so this is really good, and hopefully we can add NLP and L. First of all, forgive the, this has a lot on the slide, but it's mostly to illustrate the spectrum of advanced analytic applications and technologies for how insights are generated from data. And so the methods range from less complex advanced analytics to the more complex analytic methods that involve machine learning and deep learning on the spectrum. And so the AI and machine learning are really at sort of on the continuum of our traditional statistical methods, except that with traditional statistical methods that will say X causes Y, mostly linear, AI and machine learning can say X causes Y, but there's also A, B, and C, and this is the degree to which it's caused, and B and C also it's included to make this change, right? So it goes into more depth. It tells you a change in Y, and it deals not with linear relationships, but with complex relationships that we know that health is, right? Health is complex. It's not just, a person, but you have the environment, you have the social environment, behavioral, you have your clinical data. And so that's why AI being used to really identify the effect of the magnitude of the change and why, which of those factors are more important so that you deal with it is key to part of the decision making for physicians, clinicians that are taking care of the patient. So this is, again, forgive a lot of verbiage on this, but it's basically also saying there are different kinds of data that could be used. You can use retrospective data, so data that has occurred in the past, where you can say what has happened, and you look at all the data, and you look at historical data to help inform a patient or a population and how things would happen. Or you can track patients, get all their data, that's prospective data, that's what we also call real world evidence data, and look at the patterns, what's happening in patients that live in the population that lives in the community in Montgomery, Alabama, maybe the environment, because health is local. Your zip code determines your health. And so you can do that. But the point here is AI methods and AI algorithms need research, right? It's not just having the algorithms and the models run. It also needs causal inference. It also needs other statistical analysis to be integrated. And the computer scientists may know how to run models, but the eventual output for clinical decision making also needs research methods. And that's why we all need to be part of it. And we all need to advance in terms of our analysis of statistical methods. And this is the range, right? There's similarity analytics. What have patients who are similar to the patient in front of me, how have they performed, right? And that's different than when, and it could be added to algorithmic models so that you can come to a proper decision on how to best care for that patient or how to move the needle on precision medicine for patients and others. And this is where you can, include age and race and ethnicity, cultural norms, neighborhood context, genomic data. They all need to be included as part of the AI mission. I think I wanted to give you just a few examples of how some of these AI machine learning approaches are used for answering research questions. So this is just a layout, right, for a question like, what is my patient's risk of developing a condition X? Maybe my patient has pre-diabetes or a family of diabetes. And so what's the risk of my patient based on similar cohorts that I'm seeing? Right. And so predictive modeling is going to look at all that data of similar patients, they're tracking. And so you could see on the right hand of the screen, a set, they look at sort of timeline. Each line is a different patient, right? And so there's a prediction window that defines how much time before the disease diagnosis. And the observation can be 1 year, 6 months, right? But this is sort of the layout. And you're looking at all these points that are data points. On the left side of the screen are different approaches or methods that they are used. And so you can use what's called automated feature engineering and selection methods, where you can extract salient, relevant features from real-world evidence data. So it's real-world evidence data and collect all of that. And then the software engineers or modeling can look at predictive modeling methods that would address some of the challenges in missing data. So we'll go and what are some of the clinical data missing? What are social data missing? Personalized predictive modeling do not focus on a single global data, but they can look at patient-specific local models where they can include in that. And then multitask learning looks at multiple risks that can leverage risk across information and look at associations in this. So the point being here is that the right research methods to answer the right questions is what we need. And maybe that's what's not happening right now, but there's a push for that so that we can get better outputs from our AI and machine learning models. This is another example, a second example that's often used to predict clinical pathways, right? What's the best treatment, for example, for my patient? Let me give you an example. There are several classes of drugs that have been approved by the FDA for treatment of type 2 diabetes. There's several clinical trials, over 7,000 clinical trials that are registered around the world, and most of them are looking for novel drugs, new drugs. And then we know that these drugs need to show meaningful reductions in hemoglobin A1C for patients with glycemic control. And now sometimes you also need to show that they have improvement for patients that may have other conditions like cardiovascular disease, right? And so a lot of drugs are in clinical trials are maybe combining those who have cardiovascular disease, who may have congestive heart disease or they may not include that, right? Or chronic kidney disease. And so when you have data and you have patients that have been put on different type 2 drugs and you have diabetes drugs and you have some of them with different high risk, you can generate a picture like this to help you figure out time T, my patient looks, has the similar features when they were put on this drug. This is, how long they took to get their hemoglobin A1C under control. And so this is all data, right? And if you can have data that would give you this insight, you can make better decisions for your patient and not just throw any drug or use the old drugs that may not be working and have been working in patients that have just type 2 diabetes, but may not have cardiovascular disease or depression or others. Instead, and you don't want to just give patients drugs that will control every symptom, right? I mean, and that's why we have polypharmacy, because they're not put on the right drug, and then they keep on adding drugs that would cure every symptom or risk side effects that happens. So the collective goal of AI and machine learning is really, really to be able to truly personalize medicine. And especially in this era where patients are complex, you don't just have the controlled environment that our clinical trials currently have, because clinical trials are just looking at one disease context and they do not include patients that have multiple diseases. So those are just two examples I wanted to share with you. And so there are several applications. This is just a slide of AI in healthcare, from the clinical translational research to looking at clinical pathways. We now have patient-facing apps where, you can track patient symptoms, but there's so many types. This is just an example of AI applications in healthcare, especially in primary care, again, where you can build health equity dashboards. You can build clinical management support tools and so on. So I hope this was helpful. I wanted to make sure that I go through all this. So let's go back to AI ethics. And in terms of AI ethics, it's really multidisciplinary field. And the main goal is to optimize AI's beneficial impact while reducing the risk of adverse outcomes. But in doing this, the outcome is to prioritize the, human agency as well as how they can flourish around the environment. We want to promote well-being as well. And there are many dimensions of AI ethics, right? Ranging from accountability, ranging from the impact of algorithms, where you have to do algorithmic impact assessments. It also includes human-centered design around the tools, certainly addressing bias and discrimination. There's a lot of focus on bias, but there's a lot around AI ethics that I would ask all of us to consider when we're building your agenda around AI, your bioethics, CCTS. Value, trust, transparency. We can share the paper. I think that the show that had circulated the paper that we published, and basically talked about how we can integrate health equity and social justice into the development of AI this cycle. Now, I do want to focus on bias because that's what I'm working in and what I was asked to also focus on as part of this talk. And it's a general concept, right, that refers to the fact that an AI system and the way has it been designed, whether intentionally or not, makes it unfair, right? The decisions or the outputs from the AI tool is unfair and frankly harmful for patients and clinicians. And there's been a lot that has been published, but the focus has mostly been on the AI tool itself, the model implementation. And this is a graphic from one of the recent papers that illustrates the categories that they look at in terms of AI bias. So it looks at data collection process, it looks at data pre-processing, how you developing the algorithm, and how you're implementing the model in advance. But I want to share some pointers for us to go outside of the box when we're thinking about AI bias, which are these 5 E's. And I'll go into a little bit more detail on what I call the 5 E's. So it's the science evidence, the experience or expertise of the workforce, data exclusion, environment, so social environment, fiscal environment, and the 5th one is called data empathy. So bias, basically science evidence relies on data, right? And so it's very important for researchers, for scientists to ensure that the data that we're collecting and analyzing is inclusive and it's accurate and it's representative of all groups or the true situation and not just the controlled clinical trial environment. So we need to think about, we really have an evidence bias, right? Stemming from our research translational bias. Clinical decision making, as most of you may know, is informed by a synthesis of evidence, a current clinical decision making. And this evidence is tied to clinical trials. It's tied to real world evidence data, right? And so what makes up that evidence for decision making? It's not inclusive. Who defines that evidence? It's a bunch of people that sit together on consensus table and say, we looked at these trials and here are the standards. for the general population. But we're using that right now as part of clinical decision making. And so if these clinical trials, if these research trials, practice-based guidelines or consensus studies are inclusive, we will continue to exacerbate existing disparities in outcome and in outcomes. And we will not be able to benefit the communities that are really impacted or burdened by diseases. And so we need to think about our science, how it's funded, who is funding it, because sometimes I was at the NIH, a lot of great science was funded, but not all of that. And some of that, a huge amount was not funded, right? Because you only have to get a certain score. And what about the others that did not make the score? They were all good science, but the money did not get there because it was limited money. And so think about that. A lot of great science that cannot be NIH funded or published to get to be part of that evidence. And so we need to think about that. Okay. So we all want our doctors, clinicians, public health team to make the right decisions for us. We all want the right decisions that will make us feel better. And so our health provider expertise, our experience is really an integral part of that patient data. Because if a physician or a nurse takes a pen and write it in your medical chart, or they type something in and say, this is a problem patient, I think this patient has XYZ, it's going into your data. Okay, and think about the action, right? The tests, the stories that they included in your medical chart. Think about the tests that they are performing or, writing so that you get these lab tests or images and the diagnosis that they make. It all impacts the treatment. So we need caring, compassionate providers that would really listen to the stories and translate your symptoms and your disease into a way that would provide patient-centered care. And so we need to also look at how our policies are promoting workforce equity, workforce diversity, because we want to make sure that the care they're giving to us, our patients, our communities, are focused on the relevant evidence and focused on information that includes or considers the patient's true needs, right? Their preferences and their values. This is often what we focus on, right? And it's important, data missingness or data exclusion, because it's critical. And so we need to think about where are we getting these data sources or real world evidence data, how these data types are captured. Because a lot of the time, what about those who may not make it into the ER or the hospitals or may not have that robustness in their healthcare data profiles within healthcare systems? Their data will be excluded from the AI machine learning algorithms. An important factor is environmental data, neighborhood level data, right? Because studies have shown that exposures at the environmental level, at the neighborhood level, have a greater influence on our health. Although maybe at an individual level, you may have genetic predispositions, but environmental and social factors play a much larger role than other factors. And so it's important to integrate data on environmental aspect as well. And then finally, wanted to talk about if we want to promote data science around AI and health equity. A lot of the time, AI and machine learning algorithms are quantitative. And so data empathy is including that qualitative aspect, right? And so it's data points from the stories, from the emotions, cultural aspects, how that really cannot be quantified in data or in our AI machine learning models or technologies. And so we need to look at that. We need to include that as part of that decision making. And that's why in healthcare and in medicine, we cannot just have an AI make decisions. It needs to be the AI tool as well as the healthcare provider or the professional also looking at that and making decisions that would help the patient. So let's see what I have next. This is basically the 5 Ds, right? Evidence, science evidence, the experience, exclusion, and environment, and empathy. And I just pull it together in the table. I have key points that I wanted to make. The first one is that it's really important for us to identify and mitigate disparities, misinformation, all forms of bias, not just model or algorithmic bias, right? AI bias is all the science, the workforce, as what I've shared. And so we need to look at the entire translational and technical development steps. The second point here is that data collection efforts need to really integrate the complete context of a patient's health. And we need to look at data that is using data points from the relevant efforts, evidence, but also data from similar patients to make decisions and consider that patients' needs, their values, their stories, their life course experience, and the true determinants of their health. And the third point is building a culture of responsible data and innovation. We need quality data sets. It's not enough just to have quantity or large volumes of data. In fact, in a data set, when folks say we have 100,000, data points here, someone who has, probably 80,000 and it's more diverse is a better data set. So usually quality and diversity trumps the quantity in AI and machine learning. And then needing to really promote ethical and trustworthy AI. So I want to talk about, I really think that AI and applied machine learning and our tools, even though they present unique challenges, I think it holds tremendous potential if we really do it right. Because we're about to experience a major transformation. We're starting to experience it, right? And the transformation can be a good path or it can be a dangerous one. It all depends on how we define its course. So we have an opportunity here to really think about how we can address and eliminate disparities and be inclusive, include our communities, how we're going to leverage all this big data and make better predictions, make better decisions. There is a promised opportunity, here. I am optimistic about this. I think at the very best, we all agree that we need data privacy. A lot of us agree that we should be notified at a minimum when AI systems are being used or who is using them. We agree that we need to be protected from all forms of discrimination and bias by AI tools. And we agree that there should be standards set for AI, but we should be at the table to set those data standards and not let the standards be set for us. Right. And so AI tools need to advance community values, patient values. And since we're all, leaders, we need to make sure that we are ahead and we, really promote that and definitely make sure that all leaders think about responsible AI, think about equitable AI. But ultimately, I think it's, up to us in this room and not to, the technology developers to set us up for that equity, that inclusive and responsible AI and value-driven and innovation that we really need in the healthcare space. So thank you very much for listening. Yes. Yes, yes. Oh,
Let's see if the mic is it's working. You don't have to if you don't want to work in a nice venue. I will start using the mic though. It sounds like I've been asked to do so. I have a couple of questions prepared, but I would like to make sure that I open up to the audience first. If anyone has a burning question that they would like to start the session. I'm going to go to this table, and I'm going to keep tabs of the order. And I'm curious if folks would say their name too when they, say your name, where you're from, and then your question.
Beautiful. Good morning, everyone. My name is Stacy Lloyd from Tuskegee University. Amazing presentation. You have given me so much to think about because I do believe I've been thinking in this area before I really knew it was an area. I have a lot of questions, but I'm going to stick to two to give time. One of them is early on in your presentation, you mentioned continuous data, and you were talking about it from what I perceived from the perspective of monitoring devices. So the first thing I thought of is, there are devices now that are monitoring patients with diabetes and different things, or like implants and things of that nature. And I'm sure they probably have them for other things. That's just what I'm most familiar with. So I wonder, one, how much of that information is actually being integrated, and have you seen it, or is the plan for any of that information that's being collected to change or at least improve what we call the normal standard of care, right? So standard of care, like you said later on, is based upon evidence and common practices. But are we using some of this continuous data now as a way to inform how prescriptions and diagnoses and things of that nature are being made?
So great question. And the answer is yes. Depends on where you are and who's using. So I am currently Chief Medical Officer at Marti Health. And Marti Health is a early startup health equity company that initial focus is on patients with sickle cell disease and their caregivers. And I think we all know that sickle cell disease patients, to me, are the most, they're treated worse when they, get to the emergency room when they're crisis. I mean, we call them sickle cell warriors because they have to battle a genetic disorder, right? That makes their cells sickle, and they endure a lifetime of pain crisis. And then they also have to battle the healthcare system that discriminates against them when they basically get to the emergency room, and all they're asking for is to get better for pain medicine. As children, they're not called drug seekers, but when we get to 18, these same hospitals are calling them drug seekers for the same pain medicine they want. So what we're doing is basically that we need, and sometimes there is a phase where patients with sickle cell will have symptoms before they get to a crisis level where they have to get to the ER. So they really need continuous or monitoring, right? And so, yes, we have, for some these patients, you need them to basically, provide, their sleep patterns or how well they're hydrated. And they can do that on the app and enter those symptoms. I think there are other apps out there for patients with sickle cell. So they entering those information, their symptoms, and we're hoping that we can use this with, personalized case management, because it will trigger, right, when they're not feeling well, so that we can intervene before they get to a point where they need to get to the emergency room. So there is that happening, right? Where there's case management and making sure we're tracking these symptoms, sleep, hydrate, stress level, fevers especially because that's also critical, and so my point is that is happening, but it's not to the point where, it's we probably need that for a lot of patients with complex, congestive heart failure or COPD. And it may be happening in isolated areas as pilot. Ours is certainly like unique where we sort of just starting so that we can develop personalized treatment plan, or we can watch out because when you see one patient sickle cell, you've seen only one patient with sickle cell. And so it helps us to make sure that we're carrying, we're intervening, providing preventive care. The social workers going out there, the nurse will be calling, and following up. So yes. And the plan is, if this is happening with patients who have complex needs, I think it's good for the kind of monitoring so that we can intervene before the disease progresses. There are a lot of startups that have apps to manage these types of
diseases. Thank you again for a great talk and for teaching us. My question is that my concern from being born in America, living here, all the bias and discrimination. What do you consider some safeguards that could be put in place to kind of reduce that?
So bias and discrimination within the healthcare system.
Within the healthcare, yes. And
That-
with the AI, and with everything that's going with that, how can we do some things to safeguard it? Because we're going to have some problems. We already are.
Yes. It's a huge issue. I mean, how do we? I think a lot of awareness. First of all, there's bias that is conscious, and that's a huge problem, and we need to deal with that, right? And then there's also bias that's really unconscious. People sort of think it's the norm. And so there needs to be a lot of awareness and a lot of training and a lot of advocacy work. There's been bias training or discrimination training. But I think leaders, we may all know and are conscious and we're intentional about, not, addressing biases, but you're right, sometimes we need to really get to leaders. So I would say a lot. I mean, when I was at IBM Watson Health as the Chief Health Equity Officer, this was even before, the Chief Health Equity Officer was a thing. Right now, every organization is hiring. But I went there with, I said, I'm not going to be part of your team if you're not going to think about how you integrate health equity into your technologies. And so it took probably a year or a year and a half to train and educate and basically make a point about the return on investment to their leadership before they bought it into health equity, or before they could buy into, yes, we need to make sure that we're addressing biases. And so one way is thinking about making a business case that would tell them that, disparities are costing you, and bias and discrimination in your healthcare system. It's leading to a workforce or a population that are not achieving their optimal outcomes because of the way, the healthcare system or even structural things are set. And if the US wants to be ahead in productivity and science and healthcare, we're doing worse, right, compared to other nations. And so making sort of a strong point, sometimes we'll get to the leaders, because I think that's where the issue sometimes lies, or the problem with making them not, just focus on profits. But they could make more profits, I would say, if you think about addressing these inequities, because my goodness, without disparities, we would be, yes, killing it. I like that. So great point, but I think a lot of training and awareness and advocacy and putting money, investing in efforts to address AI bias. Thank you for the question.
Good morning, everyone. My name is Bernice Frazier. I'm with the Macon County Healthcare Authority in Tuskegee, Alabama. And I first want to thank you for a very good, comprehensive presentation. You addressed a lot of concerns that I have had, and I have a lot of questions, but I'm going to try to limit it to this one particular area. When we're talking about the data that is input, a lot of areas, especially in rural areas and communities of color, information is not being put in any type of database. One, are you suggesting that there should be a national or international database collection? And then if so, should it be mandatory that to receive certain kinds of either medication or funding that physicians and clinics and hospitals have to enter in basic data? Because a lot of discrimination, there's a lot of information and data that's entered now, but it does not include a lot of people of color, like you said, sickle cell anemia, those things that are germane to us. That information is not put in. It's also discrimination in age, gender. So how do we, my question to you is, do you think that may be a way to make sure that we have inclusive data, and then that is put in and looked at and watched so that it eliminates those biases that may be available? Thank you.
The answer is yes, and it's a great question. Local data is usually the best data, right? But we started with sort of a national. They are national. International is good, but I think we have different U.S. national databases, but it's not inclusive. With rural, I think it's good to have your own or regional or local data sets, right? Eventually, at some point, because this would probably definitely solve all the sort of disparities issues, because with local data sets, you have all the social data, environmental data that can be used and analyzed, integrated into the AI or analytics. There's a lot of data, but I think it's not getting into. So the answer is yes. Best to have local or regional data. National data sets are good because then you see more diversity. And sometimes patients will move, right? But for international data sets, that's usually good for rare diseases where you may not have, unique data sites, or you see that disease progression that you may not be able. You can only get information if you look at other international data sets. But definitely for certain, unique diseases, or even looking at treatment plans, having sort of either statewide and then sharing that data. But I think we also need to talk about, standards for data sharing, because there's a lot of hospitals all have their data, but they're not sharing it. Because we still need to build in some sort of safeguards, because not everyone will be using the data for good, right? And that's where I think a lot of fear is, like, how are they using my data? And so that's another issue, how can we avoid bad actors from getting, this data? And I think, maybe if we get to a point where, you pay, data is an asset and it's your data, but you need to get the benefits out of it if you're going to give it away. But the point is, the more data, the better. If, in a rural area, having their sort of data sets would also be good. I hope I answered the question, but depending on the research question and what you get.
Okay, good morning. Yes, good morning. I am Sana from Ski University. Thank you so much. That was just outstanding. And you talk about a lot of things that I know in the area of my expertise. I am expert in risk analysis, especially in risk assessment, development model, regard to the disease and mitigation and these kind of things. So my question is, in the presence of AI, how likely do you think that health disparities in place like Alabama's Blackbird counties could be reduced or eliminated in the presence of missing, a lot of data, a lot of challenges? How do you think that can help us, to reduce and even eliminate the health disparities?
Yeah, that's the goal, and good question. I think it's going to take time. I think AI needs a really good data infrastructure and a team that is going to take on the accountability for building that data set, and the team will include the public health department, the schools, the stakeholders that are part of the health, the policymakers as well. And you may have some sort of baseline data, and you can identify what's missing and bring in sort of, researchers and expertise to look at how best can you build that sort of data architecture. But improving the workforce around AI and machine learning. I think we all need to have some foundations, the foundation of how AI and machine learning is, to understand. We don't need to be, software engineers or computer scientists, but just having, I think it's gotten to a point where I think we all need to really understand the foundation so that we can point out what's wrong, what's missing, and what needs to be included, because we are researchers, or, health professionals, and we know the factors that influence health, and advocating for those data points, sitting at the team, and making sure that's in the data set is critical.
So I have about 7 or 8 questions in the queue. I'm keeping track of hands pointing, so I'm going to work it roughly in the order that I see the signal. So forgive me if I don't get to everybody, but.
Hi to everyone. I'm Kat Cartagena from the University of Alabama at Birmingham. I have a question. I have so many questions, but thank you first. Thank you for your outstanding presentation. It brought me a lot of questions and a lot of concerns also. So I have a quick question: is how all this new era will be impacting foreign cultures, who also are so many other barriers like understanding, trust, or either behaviors or belief when they're here in the United States? How all this data will be impact, including the bias or either any other missing information?
Wow. This is where I always advocate for the, everyone to be at the table. And, that may be missing, right, in the data sets. And so, bringing leaders or community members from, foreign, that have different cultures and speak different languages, the entire, the Hispanic populations.
and having them at the table. And I think it's building trust in those communities and a way in which we can sit down and talk about their needs and how, their data may be, missing, right? And how eventually we may need to, you know, I, I think it's a process and we all have to do that in our communities and figure out a way to sit at the table and talk about how best to improve their care. And the best way to improve their care is with their data because they're receiving care right now, but the data or, what is being used, it's not representative of their true health or lived experience, and which is a problem. So I think a lot of teaching and education and awareness and making sure that's inclusive and pointing it out. You need to say, hey, you have not included this population in your efforts and you need to do that. Thank you for bringing that up.
Hi, I'm Carrie Oliver with UAB. I'm over here. When we had stem cell technology and then the whole genome sequencing and cloning and everything, the policymakers lagged way far behind. And so it was kind of a wild, wild west situation for a long time. And I'm wondering where policy is on AI, because until those things happen, until the highest levels in the country start making decisions about it, especially use it in medical fields, the funding to support the infrastructure for AI will not be present. We will not get money from insurance agencies to be able to use this technology and upload it to places we need to upload it. NIH won't pay for it. So until that happens, I'm just curious where we stand.
Yes. So recently, and great question, you're right, in terms of policy. Recently, the Biden administration put together they have a framework for promoting ethical and inclusive AI. It's a document about 300 plus pages, basically to help lay the foundation to build standards for ethical AI. Yes, so that's out there. I think we can send that to everyone or put that out there. So states have started to think about the policies. There are coalitions out there. I'm part of a coalition on health AI, Duke University, Mayo Clinic, a group that are starting to build AI assurance labs or look at how you can evaluate AI tools. And so that's out there. There's been thinking about that. The FDA is also thinking about, standards for AI, which is all out there. So they are slowly looking at this issue and trying to figure out now. In terms of funding, I think there still needs to be a movement or push to really look at funding for that. Where I'm coming from is it's even larger than just the models, right? We need to really put money into or invest into those communities that are missing, invest money into missing data, or even giving states or institutions enough investment to build these really robust data architectures, because it's only, they're really siloed and they're in academic institutions that may have a lot of money, and so they build their own data sets or sometimes health plans, and they're using that but that may be not relevant for population here like Alabama, right? So funding or investments need to be that, and maybe policy that state could look at that and look at the investments can be made for leveraging the data that's generated here.
Dr. Dankwa, I'm Bob Kimberly from the University of Alabama, Birmingham. And first of all, I want to thank you on behalf of everybody who's here today and those who are here online. This has been fantastic, and I hope we can continue all the way through lunch in the discussion. But I'd like to come back to your time when you were at IBM and perhaps to have some insights sort of behind the curtain when you were working with Watson. And two related questions. First of all, you made the point that whether we're talking about AI, that large umbrella, or we're talking about natural language processing or machine learning, we're talking about algorithms. When you get an answer from an algorithm, how do you know that it's the right answer? Because in some conferences I've been to, you might ask the question with several different algorithms and you get at least that many different answers. So how do you know what the right answer is?
You may not know what the right answer is if you do not know the features or the variables that would, first of all, the source of that data. You need to find out what the source of the data is. You need to know how diverse that data was, and also what variables. So for example, if it's, I'm just giving it, the answer that they're giving to a question around, is my patient at risk for this, right? Just give a simple one. And they say yes, because XYZ. If what they used, the data set, did not have the relevant features, it did not have the environmental issues, it did not have the social data, it did not have relevant local data, that answer may not be completely right. And it depends on what methods were used. And so you would have to then look at other, decisions, or look at the research, or other evidence, qualitative method to come to the right decision. And you make there's a good point there that you don't need, in medicine, we have to be careful about relying on the output from AI. And that we need to make sure that we're using all relevant sources of AI. I think we've not gone there yet, but I'm hopeful that we could get there at least, and where we could say, oh, this AI output is 80% right. And that I've also looked at the context of the patient's lived experience. Okay. And I can see this is the right treatment.
Thank you. Can I ask, I don't know whether this is an easier or a more difficult ancillary question. Is there a way to know when your algorithm has an implicit bias as opposed to the explicit biases that you were just alluding to?
No, there is. You can always only try to minimize that by the methods. I mean, right now, I think all of our data can have some implicit biases in it. And the best we can do is to reduce that, right? And the best we can do is to think about what I usually call data empathy. What other stories do I need to bring into the picture to make that decision?
Thank you very much.
And you asked me about your question about IBM.
Well, I thought that when you were at IBM and probably working a little bit more closely with the software engineers and the coders, where the structure of the questions and the structure of the analytics are being put together,
yes,
you might have gotten some special insights into what kind of decisions are involved in creating those algorithms that may not be immediately apparent to most users. But that's probably a different level of question that we'd love to pursue at some time during the day. So thank you very much.
And a reminder for those joining us virtually, you can also submit your questions as well through the online chat. We welcome those questions. So I'm going to make my way across the room over here. And Dr. Neal, I believe you had a question.
First of all, wonderful presentation. I'm not surprised. Okay, I have a question that I'll ask you later because it's more technical, but a comment to what Ms. Fraser pointed out in terms of abundance of data from rural areas. When I was in my previous institution, I often visited the Mississippi Delta on cancer prevention trips. And there I met this wonderful community activist who had collected enormous amounts of data on cancer in her area, which included counties that had only one physician, all of which was on pieces of paper that were sitting in large folders, and most likely no one will ever see them. So maybe we need some investment in harvesting data from hard to reach areas, doing so ethically, of course, but otherwise we're going to perpetuate a bias in having data coming from large metropolitan areas where they have multiple EHR in their health systems and stuff like that. And you still have a lot of stuff on paper that somebody will have to capture at some point, and AI can do that very well. But I just wanted to hear your thoughts about that.
Yes, very true. And that's why I mentioned that even establishing a data infrastructure, even if it's collecting, there are lots of data that's probably on Excel spreadsheets in people's laptops, but there's rich data in there. And so really harvesting that and making sure that we can, help those who are collecting those data to make more, develop more insights, and have some analytics tools to help people. Yeah. So that's sort of the missingness, right? Where you only see those who are in EHR systems or have health insurance that would collect that kind of data. Benefit, those benefit, but instead.
Thank you, Dr. Dankwa-Mullan. We're almost done. We're doing great. We have about 10 more minutes or so until we break for lunch according to the schedule. So thank you for hanging in there for the endurance Q&A session.
I want to find out about how many are, sort of level of knowledge of AI. How many here knew about artificial intelligence or a little bit before that? Okay. And how many of you are using ChatGPT? Oh, awesome. Okay. And how many of you would want have a conversation with your healthcare providers about your data and sharing your data? Ooh. What? Okay. And so why is that? Skepticism about sharing your data.
I think my skepticism goes back to the innate bias that I mentioned in my original question, and that has to do with what are you going to do with my data? I know historically what has been done through people of color and studies and research, and then way out on like the what do you call it? Really at the stratosphere. So let's say I have a researcher and all this data is in this national database, right? And so I want to come up with a generic way to eliminate a certain kind of people or a certain kind of individuals that have blonde hair or blue eyes or brown hair or 5'3". So if I can come up by using that data, that I can come up with something that will attack that. That's on the far spectrum of that, but that's what some people think about. You have all of the science fiction movies that are out and what artificial intelligence can and cannot do. So I think that's that. But I am at the precipice where I want to discuss it. I'm not saying that you can't use it, but I want to discuss it and have more information on it. So that's my pitch.
Any other?
We have another question, but we're
Question,
going
please.
to show a little reciprocity with our keynote speaker here. So before I pass you the mic, if you would answer her two questions: have you used ChatGPT? And would you expect a conversation with your doctor if they're going to use your information to feed the algorithmic machine? And I'm sorry, you volunteered to put the question before I added this extra barrier for you.
Hi, my name is Marti Health. I'm from UAB. I do use ChatGPT, and I'm not yet sure if I would contribute, but my husband had been sick, and then I think he would be happy to share because he was a minority, and he felt like the discussion has to be started from there. So on behalf of him, I think I would contribute. My question is, you talked about 5E, and I'm very interested in the experience bit of 5E. The AI being very focused on quantitative, and then you mentioned that we have to bring in qualitative parts of it. When you put the experience in 5E, did you think about the interpretation of the AI result has to be interpreted by experience that you hear from patient? Or are you thinking that we can somehow incorporate the qualitative data into the AI to generate the different type of result from the qualitative? Is that what you are implying in the experience part?
Yes, all of the above. So when we were at IBM, where we had a Center for Artificial Intelligence and Research and Evaluation, we were a multidisciplinary team, and there were qualitative researchers who would, some had anthropology background, some were linguistics background, and they were dealing with the natural language and then natural language processing experts. And so, yes, it's all part of thinking about a way in which we can integrate those qualitative data points as well, because now it's mostly quantitative. So I think it's definitely both. And our team had, I never, imagined human-centered design researchers. And I think, we need to think of outside the box in terms of having various perspectives. But we're always missing qualitative researchers, and they were a huge part in an asset to the team. And thank you for being willing to think about sharing your data, because we'll have missing data.
Thank you. We have time for maybe one or two more questions. If folks want to ask a question, we'll have a nice plenty of time over lunch. I was already asking questions before she even stepped onto the stage. So in this nice intimate setting, please don't hesitate to introduce yourself and ask her a question over lunch or afterwards. So our next question goes to you.
Thank you. Very nice lecture and very insightful. I have a question, which is extension of Bob's question about algorithm development and uniformity of answer in terms of generating the data. Do you think that structural racism is included in it, or home violence is included in it, which affects a lot of healthcare?
question is whether structural racism is integrated into our algorithms, or how we
The algorithm that
identify.
you develop, yeah.
And I would ask how you defining structural racism. Because
A
there
lot of
is,
data on structural racism that affects health system.
yes,
So whether that is included in making decisions, that when you are deciding algorithm about outcomes, whether that has been taken into consideration or not.
so I I don't want to speak for all algorithms, but definitely there is, if the algorithm model development is not accounting, because I think it depends on how you look at fairness or parity, or how they're developing that in the model, and whether how they're using race and what outcomes they're looking for. But that's usually a fear, whether the algorithm and the question that you're asking is really propagating racism, right? Because if, for example, you're asking about, we know that Dr. Obermeyer in his research that identified the question about, there was an algorithm that was asking about cost, right? How could health plans or hospitals reduce cost? And they're looking for patients that were spending more at high cost so that they can provide case management services for them. And because of the question and the output or the outcome they were looking for, it really perpetuated racism, because those that were at the high cost, right, were not, Blacks or minorities that may be on Medicaid and were using the system less, right? And so it has that potential if your outcome does not have an equity lens to it. And so I think at the moment, those that have been out there, the algorithms have that are at risk for perpetuating racism. But if they go back, I think some of the health plans of those that were using this algorithm went back to really analyze it. Then yes, they would. It might not, but that's a great question that it could, depending on what your outcome is, what you're looking at, and you're not really saying, even with the outcome I'm looking for, looking at cost, I also want to make sure that I include an equity lens as I'm developing the methods. So I hope that answered your question.
Thank you. Dr. Dankwa-Mullan, thank you very much for your presentation and taking our questions today.